Thank you so much, Dr. Harbanch, for that insightful presentation. Now we know how much mathematics is involved, and that's why Dr. Arup called you a thinking surgeon, because there is so much thinking and planning involved before we choose the correct IOL when we plan for a toric implantation. And thank you so much, Dr. Ramesh and Dr. Chandrasekhar, for those useful practical tips, which would be very useful for all beginner surgeons who are planning for toric IOL. So we'll take up some queries. And the first one is whether optical biometry is a must. Can we still use manual keratometer or autokeratometer values and ultrasound biometry with the online Barrett toric IOL calculator and still plan for a toric IOL implantation, especially for beginners who do not have the optical biometry set up in their practice? Is it advisable?
Okay, I'll just take this question. So it is optical biometer. Biometer is a good device to have to give you more precise and accurate results, but it is not a must. It is not mandatory. If you are comfortable with your manual keratometry as well as immersion A-scan ultrasonography, you can definitely use this basic equipment and produce wonderful results. Can they be used with Barrett online toric calculator? Yes, this can be used with the Barrett online toric calculator, provided you have done a immersion A-scan for your patients. And in that situation, the IOL constant that is used for the lens is the one that is for the ultrasonic A constant and not the optical A constant. So this thing has to be kept in the mind. Otherwise, the results may not be what you had really desired. So this is my point of view. I would invite opinion from others.
Arup, I totally agree with you, Arup. As far as the A constant is concerned, we actually have three A constants. One is with the contact method, one is with the immersion method, and one is with the optical biometry. So all three will have different A constant. So the A scan with the contact will not be the same as the A scan with the non-contact. So when you do immersion method, you must reduce 200 microns, 0.2 mm, and then you can put it into the calculator. There will be a 200 micron difference because the A scan is getting reflected at the anterior surface of the retina. So not reduce, you have to add. With the immersion, you add 200 microns, and then you can use the same calculation as the optical biometry.
Yeah, and I think it is a good idea to have a topographer, a basic topographer. That this is to rule out the conditions which I think Dr. Harbanch had already mentioned, and Chandrasekhar had already mentioned, that situations which are contraindications for toric intraocular lenses.
Actually, Arup, what I always say is the rule of two. That means if you got an assistant and you do the manual keratometry and your assistant does, and if both of you get the same axis and the magnitude, you could be pretty sure that it is all right. If you do not even have an assistant, then if you do it one today and one next day and see whether there is agreement on the two. And if your keratometric values are matching with the reflective spectral correction of the patient, then you could be quite sure about your keratometric values.
Yeah,
so just one, if the confidence is say 50%, if two of them are matching more others, you could be 90% sure that you are correcting the right toric IOL. And of course, the finer, lower keratometric values, lower astigmatism, probably you will not be able to correct with these methods.
Yeah, I agree with you. So in the dry eye workup is very important for all the patients who are candidates for toric IOLs and the premium lenses. And another thing that I do is, I always repeat these measurements, even if the first measurement is okay. I'm talking only about the toric lenses and the lifestyle intraocular lenses, the multifocal lenses. And I just repeat it the second time, and if there is a concordance, then I'm doubly confident that the results are going to be good.
So the next question is about measuring the K values using multiple equipment. So you had mentioned that it's good to repeat it and see the similarity of the calculations, but is it good also to use multiple devices? And also, can we combine like the K value from one device and the axial length from another device and incorporate it in the online calculators?
Ramesh?
I think this was answered by Dr. Chandrasekhar Bhavikar. He mentioned that you can take it from 3 different instruments and get the integrated K function, which is slightly better than just taking any one. And it's always,
especially when there is a disparity, then we can take the.
there will always be a small difference. No 2 instruments will give you the same value. And we should not underestimate the value of the manual keratometer. With the manual keratometer, we can see how good the corneal surface is. All the dry eye, all these issues, we don't have to read the spots. When you see the ring, we'll know whether the toric lens will suit the patient or not. So if you have to use any one instrument alone, I feel manual keratometer is the most important one.
The only drawback is manual keratometer is dependent upon the operator.
Yes.
And most of the time, because we do not do now.
We have to do it, sir. For a toric lens, we have to do it.
No. But what I'm telling you, I mean, it's fine if you do it, it's okay. But most of the centers, most of the eye surgeons are not doing it. And many of them may not be even having the availability of the manual keratometer. So if the manual keratometer is operator dependent, so that has to be very, very clear that who is operating it.
Ramesh, which are the vendors are dealing with manual keratometers? Because I had one, and when I approached the company to have a look at it, they said, "Sir, we have withdrawn all our services on this product." So I have stopped using it. But I agree with you that when I was using it, I was quite happy with its outcome. Any vendor that is dealing with this?
Arup, currently I have the Apasami manual keratometer, Arup, and
but they don't service this device any longer, do they?
They are very inexpensive, Arup. You can buy a new one from them.
They don't sell.
They do. Apasami company will sell you they will sell you a Bosch and Lomb type of manual keratometer.
Okay, I mean, last time I contacted them, they said, no, sir, we are maybe Kerala, they're not doing it, but I agree that, that there's a lot of subjectivity involved, and the operator experience also comes into the picture.
Can I add something?
Yeah.
See, basically all instruments are operator dependent. Even if you take Lenstar and IOL Master 700, if the head position of the patient is not good, then we are going to get an error. So I think we have to pay a lot of attention to how the reading is taken. And coming to the manual keratometer, Dr. Arup, we also have the same problem. We have the Apasami manual keratometer, age-old thing, and they don't service it. But what we have done is that we calibrate it in the day, on a single day, and we found out how much error it is introducing, and we take care of that much error, and that way we are getting pretty good results.
Yeah. Next.
So we'll go to the next question, which is on the importance of posterior corneal astigmatism. How much does it affect the final outcome, and the importance of actual measurement versus the assumed mathematical values that are predicted in the online?
Can I answer this question?
Yes.
So I think I do not agree with the assumed values, because if you are correcting 85% of them, making better, 15% of them you are making worse. So secondly, the posterior corneal astigmatism, if you can measure, it's fantastic, because you are more sure. But in 3 conditions, this is more or less mandatory. One is that whenever you are correcting low corneal astigmatism, suppose you are going to correct say 0.9, 0.8, 0.75, then you must measure the posterior corneal astigmatism. When you are correcting very high corneal astigmatism, whenever there is an anterior high corneal astigmatism, there is many a times there is a very high posterior corneal astigmatism also, which I have seen the variation of 4 diopter to 0.5 diopter, 1.5, 1.75 diopter posterior corneal astigmatism. And secondly, in oblique axis, there is, whenever the patient has got the anterior surface astigmatism in oblique axis, there are more chances of having high posterior corneal astigmatism. So whenever you are correcting very high power, very low power, and oblique axis, it should be measured. That would be better. Otherwise, I do not adjust according to the posterior corneal, as I already presented in my presentation. Just when I got to choose between the two, whether to use the lower and the higher, I go according to the posterior corneal curvature, but I do not add or subtract. So if I got to use 1.5 or 1.2, I'll decide on the basis of that, but no specific adjustment.
So I just want to add one point here. With oblique astigmatism, I think Barrett's toric calculator does not give as good results as it gives for with the rule and against the rule.
Yes.
Recently, there was a study. I think there has been a series of studies recently by Shamas and his team, where they used the measured posterior corneal values using the pentacam. Dr. Harbansh, you are mentioning about pentacam.
Yeah.
This was actually in healthy eyes, not very steep or very flat corneas. Healthy eyes where predicted corneal astigmatism versus measured corneal astigmatism measured with the pentacam, and they found out that the predicted corneal astigmatism was definitely clinically as well as statistically superior to the values which you're getting with the pentacam measured.
I got no doubts. I've been doing that. And in fact, I do not use any calculator, neither the company given nor the Barrett, nothing. I just take the measurements and I mark myself what axis, what power. The points are already elaborated, keeping all those points in mind. So I never use any online calculator. I never use any company calculator. I just calculate it myself. That's it. This is the axis I want. And this is the side I should err on if there is any error. And this is the power I want. And whenever there is a short supply, then I also mark 1, 2, 3. First choice is this, second choice is this, third choice is this.
Just to take this point forward, for the young listeners here, what Dr. Harbansh had mentioned. See, for example, if when you talk about, say, the T7 lens, okay, toric lens. So now, how do I know the corresponding power roughly? So we subtract 1 from 7, 7 minus 1 divided by 2. So it comes to 3. So roughly a 3 diopter corneal astigmatism will correspond to a 7 diopter the T7. So this is the rule of the thumb. You try out with all these T, starting from T2 to T9. This thing works pretty well.
I think, Arup, the different companies may have different nomenclature. So simple is whatever is in the IOL, nearly 2/3 you will get at cornea.
Yeah.
So the IOL, if it is 1.5, you will get 1 at cornea. If it is 2.25, you will get 1.5. But if it is 3, you will get around 2.06 something. So 2/3 of it will be on the cornea.
So another point I think we needs to emphasize is most of these modern formulas, even the commercial formulas, and definitely Barrett formula and Holiday formula, etc. The toricity factor is already taken into account. So you really don't have to adjust, the toricity ratio, whether you're dealing with a long or short axial length or a steep or a flat cornea. So that is the advantage of the online calculators.
But Arup, still, I feel whenever I am dealing with a high myopes where the power is coming, say, -3 or -2, +2, +3, I usually target still -1 or -1.5. If patient is getting a spherical power of, say, -6, I will target -2. If it is getting, say, +4, I will target -1.5, -1. So still I feel whenever there is a high number, you still err, and the same is true for the plus. When I'm getting a 36 diopter, then I'll still target -1 because the minus gives you a cushion, and minus at least, and I've still found that they are not very accurate at the extremes, and there are chances of these patients becoming hyperopic. They are at least more than 50% error in the extreme of the eyes. So I target on the minus side. So far as this is my experience has been on the extreme of both the sides, I will target minus.
Okay. So regarding the last question, and as I had just mentioned, the previous slide, a couple of consecutive studies have shown that swept source biometers give more accurate, precise values compared to shim-flex devices when you're using the Barrett toric calculator.
So the next question is regarding which calculators to choose. So we have had a discussion on that. So still, when there are multiple online calculators, so which is at present the preferred toric calculator, sir?
Barrett.
So Barrett is no doubt the gold standard. Nowadays for spherical calculations, I am using Kane, Barrett U2 as well as EVO. But when it comes to toric, Barrett toric calculator is really the best.
Recently, about I think last 2 to 3 years, I have been also checking up with the Ken formula. And the Kane formula has it seems to have done extremely well in post-RK eyes, in keratoconic eyes, and in post-refractive surgery eyes.
Yes.
And another beauty of the Kane formula, Ramesh, I mean, if you have noticed it carefully, the SIA factor is 0. So it is
True, Arup. Exactly.
it is
I
a
have
very
been,
user-friendly formula. Very
yes,
user-friendly
Arup,
formula.
I have been using an SAA of 0 for the last 6-7 years. I am very happy. If we all keep SAA 0, we can move forward a big step. We should not bother about SAA.
Yeah, I never bothered about SIA.
Yes.
Whenever I started the incision with 2.2, because I usually prefer incision little posterior, closer to the limbus where it little bit oozes. So 2.2 actually makes no difference.
So according to Kane, it is 2.75 millimeter incision, and the 0 center of the SIA is okay.
Yes.
So
yes.
I mean, it makes it very simple actually.
So we all go with the centroid SIA value of 0 to 0.1, and it works for any incision between 2.2 and 2.8 millimeters.
Yes.
So our next question is on how important is the ocular surface evaluation. That was very lucidly covered by Dr. Chandrasekhar. So my query is also regarding contact lenses. So if the patient is wearing contact lenses, so how long should we ask them to discontinue and come for the biometric measurement?
Yeah, very, very important question. So if it is a non-toric contact lens, they have to discontinue for 1 week. But if it is a toric lens, toric contact lens, then what I do is that I take 2 K readings 3 weeks apart. And if I feel that there are still some signs of warpage and the K is shifting, then in toric contact lens, I may wait even longer.
Couple of weeks, I think 2 to 3 weeks. And then you measure, you look for the reproducibility in the values to subsequent readings. Yeah.
And we would like to know whether there is a role for aberrometry in toric IOL planning.
I don't use it. I have no idea about.
I don't use it also, Dr. Arup.
Yeah,
So
even I don't use it.
It's an
When I'm not
upcoming
So
thing.
none of us are using it, but I mean, I think there are people who are using it in the Western world, and I think it becomes a theoretical discussion.
Okay. We'll go to the next set of questions, which are regarding the intraoperative issues. So we discussed regarding the site of incision, whether to go. Dr. Ramesh re-emphasized that always going for a temporal incision is best, because we know there are so many factors.
No, but only thing is, when you suppose there is you feel that you are putting an IOL which is under correcting 0.25 or something, then you can, if it is possible, to place your incision at a steep axis without inconvenience to you, and so that you can make a 2.753 millimeter incision, it can correct that amount of astigmatism. So you can place whenever, I mean, otherwise you don't have to plan big, but if it is something around 0.2, 0.3, you feel you are getting under corrected, and make your incision 10 or 20 degrees this way or that way, you can do that.
Sir, I would like to just just share a different point of view, and that point of view is that in any given patient, we really don't know what our SAA is going to be. It varies from patient to patient for the same surgeon, and the variation is more if you are not temporal corneal. So if I enter in the oblique or superior axis, my variation is going to be much more than if I enter on the temporal corneal. So in general, for the beginning surgeons, better to stick on to temporal corneal for the next 100 or 200 toric lesions.
Yeah, but Dr. Ramesh, actually, luckily, most of the corneas we operate in the old days have the temporal steepness. So 10 or 20 degree, and 80% of the patients will have the temporal steepness, and 10 or 20 degree of this way or that way is very much possible. And many times the lenses are also not available. And as I told you, these are the modifier. These are not planned. So when I got to choose between the two, 1.75, 1.5 or 2. So if I'm getting 1.5, I want to have 0.2 more, I'll put on an incision at a steep axis. So use them as a modifier, not as a primary target.
In this context, Nirupama, there's another question. Like SICS is the most popular method of cataract surgery in our country, in the developing world. So is it compatible with the toric IOL implantation? Ramesh and Dr. Harbansh and Chandrasekhar, Nirupama.
I think all SIAs are not, or all SICS surgeons are not the same. There is a small group of superb surgeons who are able to get predictable SIA, and for them probably it will make a big difference. But for an occasional SICS surgeon like me, I will not be doing it.
So toric IOL and SICS, they do not go hand in hand.
Unless you are a superb SICS surgeon.
Okay.
Sir, our next question is regarding low toricity. So, should we go for toric IOL, or still there is scope for OCCI and LRI in the management of lower cylinders?
So if we talk of the toricity, the toric IOL always performs better and more predictable than OCCI and LRI. But out of the OCCI and LRI, OCCI is more stable. I mean, at least the like incision, the vision will get stabilized in 3 weeks, 4 weeks time. While LRI initially may give a lot of excitement and a good correction, but slowly and slowly effects is not decreasing. There is more irritation and less predictability. So LRI should be discarded. I got no doubt about it. And even I don't like the femto LRI. I think they are just trying to sell the machine by some or the other. If the LRI is not working by incision, it is not going to work by the femto, because you're going to create much more central incision with the unpredictability. So the nomogram of the LRI, when we were doing also, I have done a full thesis on this. I have done a full thesis on OCCI with the 3.5 to 5.5 millimeter incision. OCCI is definitely better than LRI. But again, in the modern time, it is better to use as an enhancer. And OCCI is another big point. Is OCCI, if any patient is unsatisfied with your outcome and you don't have access to the laser to correct his refractive surprise, say patient has got -1. OCCI is a very simple. You find out the minus cylinder axis, and parallel to that, you give to incision 90 degree away. And you can correct up to 1 diopter, 0.75 diopter of cylinder without having any access to any equipment or any machine.
Yes.
It can be used post-operative modifier.
Can you combine it with the toric IOL implantation?
Yes, 100%. Because sometimes when I get a patient of trauma who has got, say, 8 diopter, and I'm getting the lens which can correct only 6 diopter. So I want to have little more additional effect. You can give, and I don't give OCCI incision now more than 4 millimeter incision. Earlier I have done studies on 5.5. And so now I restrict myself to 3.2 millimeter incision or 3.5 millimeter incision, and a little more corneal, and manipulate the another incision. I just don't pass the instrument there. When you're doing irrigation, aspiration, at least put an infusion from the other side. So a little bit of manipulation of that incision is recommended, and then you can have a good effect.
Thank you, sir.
Thank you.
And the next question is, how do we manage intraoperative pupillary constriction when we have already planned a toric IOL case, and during the end of the surgery, especially the IA or the IOL implantation, the pupil constricts? So how do you go ahead with the implantation?
So I think this should not be an issue, because only thing you need a people to see whether your lens is placed correctly. Placing the lens is not a problem once everything else has been removed. So you can use any hook to pull the iris away and see whether lens is well placed or not. So normally I will put nothing to dilate. I mean, of course you can put the pinocaine, which is available now, is very good, because I've been using Gilocard with Adaline for quite some time. And recently what I found is that after putting Gilocard Adaline, if I'm getting say 5 millimeter of dilatation, then I put on a pinocaine. Slowly and slowly over 4-5 minutes time, I get 1 millimeter more expansion with the pinocaine, and little sustained and delayed as compared with the Gilocard and Adaline which I was using. And of course, you can use the sodium iodinate or a thick viscoelastic to stretch it. But normally, I will not put the hooks and rings for this.
Oh, okay, sir. But if there is a preoperatively poor mydriasis, then can we plan a toric IOL with an expander?
Yes, 100%.
Okay.
Without any doubt, I think the rings are better, but the hooks are equally good. And Bhattacharjee ring is now very economical, and I think there is no reason not to put the toric
I mean,
IOL.
I think but the Bhattacharya's ring advantage is that you don't lose the anterior chamber. You can even take it up to the paracentesis incision. So you don't have shallowing of the anterior chamber with forward movement and rotation of the lens.
So only thing I'll suggest, whenever you're putting these rings or hooks, there should be some viscoelastic between the iris and a capsule. Normally, if you put on a viscoelastic on top, iris gets stuck to the capsule. And particularly if you are doing midway surgery, when your excess has been already made, then you must ensure some viscoelastic between the capsule, anterior capsule and the iris. Otherwise, you will hold the capsule over there.
Okay, thank you, sir. And is there any role for placing a CTR when we are planning a toric IOLs for high myopes, because the expanded bag may cause increased rotation? And if so, what is the cutoff axial length when you would put a CTR along with the toric IOLs?
So I think CTR, when you put it, it will not prevent the immediate rotation of the lens, because you are making actually the capsule is stretched and is smooth as compared to the crumble up over there. It is only the post-op contracture may help. So in most of my cases, like when you do desec, you put on a big air bubble to press the lenticule against the cornea, and then you release the air bubble. So same way, what I do is I put on a very big air bubble inside the eye and press the lens against the posterior capsule. And you keep it pressed there for a few minutes, because these lenses are very sticky. Even when you want to rotate it, they don't rotate very easily. The only problem is when you are trying to put it over there in the first place, whether you are able to put it at the right place or not. But you put on an air and do not deepen the chamber too much. Most of the time, we try to measure the IOP when we are leaving the patient from the table. So instead of measuring the IOP, keep the iris flat. Do not push the iris behind, because when you're putting the iris behind, the capsule is getting extended, distended. The capsule is distended with your fluid, it will have more tendency for the lens to rotate. You have to flatten the capsule, keep the IOP soft, put on a big air bubble to press it down, and don't leave a leaking hole. I don't think you will get a problem of rotation.
So the consensus is even in high myopes, don't use a CTR.
No, Arup, I have a
CTR we can use, but rotation, whether it will affect or not, is doubtful. You can use CTR to flatten the capsule, but whether it will prevent the rotation, I think it is the important is that on table, the lens should be pressed against the capsule, well pressed against the capsule. And if it is like, if you suppose you try to rotate lens in a softer bag, you will not be able to rotate well, or it will get stuck somewhere. If the bag is extended, the lens will rotate freely. So if the IOP is more, if the bag is extended, the lens will rotate. But if the IOP is soft, the air is from the top pressing it down, the capsular bag is not extended, the lens will not rotate. CTR is not, because CTR is in any case is increasing the capsular size, it is not decreasing. How it is going to decrease it? It is making it tighter, where the things on a tighter surface, you can move much more smoothly. I saw one of the presentation where they was talking about the rug, you slip more if it is tight. So the thing is, the CTR will not prevent immediate rotation.
Ramesh, your point?
Yes, sir. When this topic came up, I think they were talking not about the regular CTR that we use, but about the Henderson ring, which has got a rippled wavy surface, and the toric lens is supposed to lock onto that. But I have tried to ask our Indian manufacturers to make it, but nobody could do it for me. So how it does work, I've done it only once in some patient. There's no cutoff, but he had a very large anterior segment and a high myope. So I put a CTR inside, but left the trailing the eyelet out, and then I put the toric lens and tied the two together. So the trailing haptic of the toric lens was tied on to the CTR edge, and then both were dropped into the bag. It dragged quite a bit, and then I could.
Why don't you upload that video, Ramesh? It will be very interesting for us to see.
It is there somewhere, Arup. That's the time when I lost my laptop. I think I told you I spilled some drink during onto my laptop, and a bunch of my videos went off. So if you tie it together and then you put it into the capsular bag, the whole thing becomes quite. It doesn't turn so easily, and then you can move it to the final axis. So put them together, but tie the trailing haptic and the CTR together.
That's very innovative. So in this context, I mean, I would also like to ask the panelist and Nirupama, is the rotation more in with the rule kind of astigmatism or oblique astigmatism when you or it is more with against the rule astigmatism? What has been your experience?
Arup, my personal experience is that if you place it horizontally, that's why one of my tips for the beginning toric surgeon is please go for the ATR, and it will be in the 0-180 axis. It won't rotate so much. But more important, I find that some lenses tend to rotate, some of them don't rotate. So choose the lenses which don't rotate much in your hands. All toric lenses are not the same.
So I personally feel the putting the air and pressing it over there is more important than anything else.
What about the hydrophilic toric lenses, hydrophilic acrylic toric lenses? What has been your experience with this in comparison with
I've not used any one of them, so I really don't know. But they should be okay. I don't think there should be any problem in it.
I felt that the plate haptic toric lenses were very, very good until you choose a myope with a large valve. At that point, they tend to move around a bit. But the hydrophilic plate haptic torics, I've used a few. They're all quite good.
Okay.
And sir, any experience with the using the markerless toric IOL image guided tools like the Callisto Eye or Verion? Our query was whether this can be used under peribulbar block, or is patient fixation necessary when we use the image guided systems?
Patient fixation is not necessary.
Okay.
So,
but even if the patient is asleep and the eyeballs roll, will it still give the values, or it may show some error?
I use Verion. I do not have any experience with Callisto. As long as there is a dotted circle, if you match that with the limbus, most of the times you are bang on target.
Okay, sir.
Actually, in this context, parallax sometimes may be a big problem. When at the end of the surgery, when you're closing, and you just want to have a last-minute look whether you're aligned to the steep axis or not. The parallax comes into the picture. So I'd like to get an opinion from all three of you. Have you experienced it? And if so, then how do you tackle it?
Yes, see, parallax is definitely going to be there. It is because the Verion projects the image on the retina, on the cornea, whereas the lens is deep down into the anterior chamber. So as long as the line joining the dots on the lens is parallel to the marking on the projection, the projected marking, I think we are bang on target. We are quite on target.
Yeah.
I think Arup, as I already talked in my this thing, we should also have this side to err. One is very important. If I'm putting at 20, if I have to have the error, whether it should be towards the 15 or towards the 25. So that whenever you got any doubt, you know which is on the safer side to go. So, and secondly, many times when you're doing not in a when you're marking, your ring may not be placed equidistant from the center. And when you mark, one mark is aligned, another mark does not get aligned. So leave both the marks, either put the ring and check again, or leave both the marks equally away from your lens. Because suppose your lens marking ring has shifted onto the one side, then both the marks may not be going through the center.
Yeah. Okay. Ramesh?
Arup, I do the same way as Dr. Chandrasekhar. The reflex from the lens, optic, and from the cornea should be aligned. So at that point, I will check whether the axis is correct or not.
They'll be parallel. They have to be.
Yes.
Yeah.
And now coming to the post-op considerations. So which design rotates the least? I think Dr. Ramesh has mentioned the hydrophobic is better over hydrophilic, or they're the same. And also the haptics, sir, you said the rotation is less with the plate haptics. Is there any?
No. The specific comment that I made was the Alcon toric rotates least in my hands. That's a specific comment. And if you're using a plate haptic, it is great for normal and small eyes, but it is not good for the large bags.
Oh, but the rotation is more with plate haptics, sir, when compared to the loop
In
haptic.
large bags, they both will rotate. The
Okay.
plate haptics are great if the bag is small or normal in size, but the J loop, most of our toric lenses are J loop, but the J loop from J&J, from Alcon, from Apasame are not the same. Although the design looks similar, every one of those lenses will behave differently inside the eye. So whichever works well in your hands, you should use.
I
I've
think
been using J&J without any problem.
the biomechanics of the J&J Toric was little different. Now they have come up with the Toric 2, isn't it? So
Yes.
so where the external surface of the haptics are supposed to be frosted. I haven't used them. I have used only Alcon. But
I've been using it. In fact, many times I do hydroimplantation. I find their rotation difficult. So these lenses, the new one, don't rotate that much because of that.
The new ones are much better than the old ones, Arup. They are more, they drag on the capsule, but it still takes a very long time to release and to open up. Isn't it? Yes.
So if there is a misalignment, again, there will be difficulty to rotate the lens, sir. That's what.
You are talking about post-op?
Post-op, if we have to re-rotate the lens, then will there be again any difficulty?
No difference.
In the post-operative period, we should wait for at least 3 weeks for the back to become tacky and shrink a bit. So if initially the lens turned because it was capable of turning.
Yes.
So similarly, if you rotate immediately post-op in the first day or two, it may still do the same. So ideally, you must wait for 2 or 3 weeks, let the back shrink a bit and become sticky, and then you should.
Yes.
And sir, post-operatively, if there is inadequate power of the toricity, so what is our next line of action? So should we go for an IOL exchange or the bioptics, like refractive?
That depends upon bioptic will be always better, because whatever may be the region, bioptic will take care of the refraction, which may be a little different from the corneal astigmatism, whether it's a lenticular action, whatever may be the region, bioptics will take care of everything. Secondly, once you put a lens, if there's a little bit of fibrosis and if the patient is late beyond say 6-8 weeks, and if you are planning at that time, and then maybe single piece lens may be very, very difficult to place at a checked location. And beyond 3 months, of course, single piece lens toric, you won't be able to place it. So instead of exchange, it will be better, because again, you are doing an intraocular procedure. So the laser is much more cheaper, economical, and can take care of the patient's concerns far better. So I'll go for bioptics, not a toric IOL exchange, not a toric. I mean, if I like in an intraocular cornea where like I showed you, where there's this, you can't do bioptics, there is no other option, but not correcting the toricity is entirely different. But in a simple, straightforward case, the laser is far better option.
Any other opinion on this? We'll go to the next question.
Yeah, I mean, not exactly on this, but what Dr. Harbans had shown beautifully about how he calculates whether he's just going to rotate or the lens has to be exchanged. I think, sir, it is basically important to find out the spherical equivalent of the post-op refractive surprise. If it is closer to 0, most of the time, by rotation, we should be able to give a satisfactory outcome for the patient.
No, what I was trying to emphasize, because many times maybe patient has come, you're not treated with dry eye, and whatever may be the region, we need to find out whether this rotation of the IOL is going to correct the astigmatism or not. So what is, whether because of your incision, because of your side decision, because of the patient pathology, whatever might have happened in between. So what is the astigmatism today? And whether this lens which is inside the eye can correct the astigmatism what patient is having now. Only then you should try to realign. But if patient had a 3 cylindrical power and your lens can correct only 1.5 and 1.5 error, there is no point of adjusting it. So you need to find out whether this lens is capable of correcting the astigmatism patient is having now, and how much it can improve upon. And again, how much it is off axis. If it is suppose only 5 degree off axis, you put on a lens which was supposed to correct 10 and it corrected 8. It has huge number of correction, and the off-axis is only 5 degrees, which you won't be able to do it. You won't be able to show. So, and the lenses always work best in a steep axis. Forget about whatever is the calculation. You don't have to worry about anything. Just put the lens on a steep axis, you will get the maximum correction. This is where we started. Even if the lens is inside, how it is going to change these things? So the lenses work best when they are placed on a steep axis. Finish. So one single line, and you need to find, if I put into the steep axis, whether it will correct whatever I want or not. Very simple. You don't have to have anything else. Put the lens on a steep axis, you will get the best outcome. And whether putting a steep axis is possible, if it is rotation is 5 degrees, it is not possible. If it is more than 10 degrees, it is possible. And put on steep axis, and then you need to find out whether putting it in steep axis will benefit me or not. Very simple. You don't have to, I really can't understand why we need to do anything else, because put the lens on a steep axis, you get the optimum result.
So a different take on the same problem. No, we have power and we have an axis, and behind that we have one more lens with a different power and a different axis. So the interaction of these two when they are misaligned is not simple. It's a little more complex. Sir has understood it in a very deep manner, but those of us who are beginners and for whom we are not able to, we don't have that mind, that kind of a brain or that understanding, I suggest that you go to Barrett's RX calculator. There you have to input what lens you have put and what the error is and what the K is, and it will tell you whether turning it a little bit will help or whether you have to exchange.
Even the astigmatism fix.com also does the same thing, you know?
Yes, this is slightly, oh yes, Arup. This is this one is being updated more frequently.
Yeah.
So, but it also does the same thing.
No.
For the simple-minded, this is one option.
Dr. Ramesh, I really tell me why it is difficult to understand what is the steep axis now. Tell me this: if you do a pentagram and keratometry now, you will know what is the steep axis. Do you agree that if you put on a toric IOL on a steep axis, it gives the optimum result?
Sir,
I mean, where is the confusion?
Often the axis at which I'm implanting is not the steep axis, sir. It is like 15 degrees or 5 degrees or 7 degrees different from the steep axis. So the corneal measurement in my IOL Master 700 will be saying, we'll say 1.27 into 17, but it will ask me to implant at 13 or at 20 or some other axis. There's a small difference between the steep axis and what the calculator tells me to implant.
Why?
So,
why it should be so?
Yeah, I actually don't understand it, sir.
So, the whatever is the calculation, until there are so many confusing things, you are taking posterior corneal presumed or something you are presuming the incision. Otherwise, if this is the mount, this is the flat. I mean, very simple. I mean, where was the steep axis? You got to put the lens.
I think the way it is taught is this. I'm not sure, but this is my way of thinking. When we look at the K reading and we say 44 into 180 and 43 into 90, we are having two axes. But when you look at a topographic map of the cornea, every point has got a different K. And if you take the posterior cornea, the 3 millimeter axis and the K is different. The 5 millimeter axis and K is different. The 7 millimeter axis and K is different. So we are having two aspherical.
So my take on that is.
So I'll just complete. We are having two aspherical surfaces which are misaligned. They're not aligned. Now how the calculators work is they see the results of, let us say, 20 patients with this kind of an alignment, and they fine tune it, and they say, okay, it's going wrong by 5 degrees. We will change it by 5 degrees, and then they see 10 or 20 more patients with the same kind of misalignment, and they keep on refining themselves. So it is not simply that I have a K here and that has to be the same. Every K at every zone.
No, I don't think they do any refinements, because you do on a IOL calc, you put on a different keratometry, you'll get the same value with different values. What I'm coming to that. So what is important is to understand your own topography map. Whenever you see any pentagram reading in the central 1 millimeter, there will be hardly any astigmatism. So and you need to keep the patient's pupil in mind. Our Indian population's pupil is very small, 2 millimeter, 3 millimeter. So I personally feel that for us, 2 to 3 millimeter is the best, not 4 millimeter or 4.5 millimeter of the pupil size, which the West follows. And secondly, in a pentacam reading, wherever you are getting the maximum astigmatism, usually suppose the 1 millimeter will be small, 2 millimeter little more, 3 will be more, 4 will be around 3-4 millimeter, then it will astigmatism keep on decreasing. So the highest astigmatism you are getting on a pentacam and the total corneal power and the axis you are getting is most likely going to be correct. I don't think any of the formulas understand. They just, you try to put in different pentacam. I don't think they take into the consideration. They ask you, you put different patients. I don't think they are very intelligent. They have got any artificial intelligence built in except Hill RBF, which keeps on finding out the similar data of the different patients word over and then tries to give the without calculating what it could be. All other are very simple formulas. Find little bit of adjustment here and there. That's it. It's not something very great that they are calculating the pentacam value of the 4 points. No, they are not calculating the pentacam value of the different meridian. No. So they are just calculating what you are feeding them, and most of them do it on the basis of the optical biometer. So I feel that if you start analyzing your data today, you will realize that what I'm talking makes sense. That you need to keep the patient's pupil in mind. That what is the pupil size? If you get an elderly patient, 80 years old, 1 millimeter pupil, even if you don't put toric, he will see well. So you see the toricity of that. And secondly, when you do the autorefractometer, and I have found many patients who had a spectral refraction, but had no corneal toricity. And then post-op, when I didn't put on toric IOL, they had a cylindrical power in their specs. So if you start analyzing your data, you will find that even the refraction makes a lot of difference. And even you see the autorefractometric reading comes much higher than the patient's acceptance is. Because if you do the dilated AR, the automated refractometer may be taking a much larger diameter than the patient's pupil is. Patient's pupil is say 1.5 millimeter, 2 millimeter, AR is taken at 3 millimeter, and you will find that the AR is coming 1.5, but patient is quite happy with 0.75. So the thing is, we need to analyze our own data, and we need to see each and every point ourselves instead of, this is what I do. I do not rely upon any one of them. I do my own calculation, and I have been most of the time dot on.
Superb, sir.
So
Yeah.
I'll go and analyze Barrett, and you also analyze whether they take different points of the pentacam into the consideration. They have taken a standard posterior corneal curvature. That's the reason Samas have proved that the total corneal power of the pentacam is better. And because I talked earlier also that oblique axis, you definitely have to have the posterior corneal curvature measured, because whenever there is axis oblique, the posterior corneal curvature will have more influence and more effect. That's where the Barrett goes wrong. So the total, if you have access to the pentacam, total corneal power is better for you, the axis, and then you need to see the pupil size, and according to that you take the astigmatism. What I also realize, most of the time the maximum astigmatism you are getting, so 0, 2, 3, 4, 5, the maximum cylindrical power you are getting, that axis is probably more accurate. That axis is probably more accurate, and you can, but if you are getting optical biometer, which is matching with the 2 millimeter of the pentacam, I'll go with that reading. So we have got to see the agreement where it is coming.
I think we will move on to the next set of questions, because we are close to 9:30. These are the questions which I think we have already covered inside at some point in time. So the next set of questions are quite interesting.
Yes, so we wanted to know whether the calculation errors are more with the extreme axial length eyes or with the high cylinder. So in your
Already has been covered.
We've already done this. Next page.
So the next is
Next slide.
regarding toric IOL implantation in a patient with pterygium, which is causing astigmatism, but not necessary to do the pterygium surgery. So can we go ahead with toric IOL implantation, sir? If it's just a small pterygium, but it's causing astigmatism on the cornea.
If you do a manual K on these patients, we will know whether the central zone is affected by the pterygium or not. Based on that, you should decide. I don't think we can go by any of the instruments.
But if it is atrophic and not causing, and if it is not required to be removed, then you can go ahead with the toric IOL. If it is not very fleshy, not very young patient, very old patient, whether you are not planning for the pterygium surgery, probably you can go ahead with the toric line. Otherwise, the pterygium should be operated first and then you should do the cataract surgery. Not simultaneous even.
Yes, sir. And the last question was regarding the use of toric IOLs in irregular corneas, which was again covered by your